Hi, everybody. This is Russ Rudish from Rudish Health, and I'm pleased to welcome you all to the very first webinar of our Healthcare Leaders Unfiltered program. Whether you are in the on the West Coast in morning time, on the East Coast in afternoon time just, or I know there are a couple of people in Istanbul, Turkey listening to us in the evening, we want to welcome you across the globe. We have three outstanding speakers, healthcare CEOs that we will have a very, very interesting conversation with over the next 60 minutes. And Paul Keckley, my longtime friend and colleague, is going to moderate the group and host this conversation. Paul, as many of you know, is the Keckley Report author that comes out on a weekly basis. He's also a industry analyst and a self-proclaimed data geek. And he's, as I said, a longtime friend and colleague and a very, very, very good person as far as at least I'm concerned. The one thing I would also add before I turn it over to Paul is that this webinar is being recorded. So if you have any issues with that, please disconnect at this time. And with that, Paul, I'll turn it over to you.
Thank you, Russ. First, I want to thank all of you for tuning in, and I want to thank Nancy, Susan, and Randy for agreeing to this. They're friends, and I think that was so gratifying to know that we're all still in the search for what's next, and we're willing to share some of our unfiltered thoughts about the future. So that's the purpose of this this discussion we're going to have. I think everybody knows all three of you. So I know you through the years, dating back to the beginnings of your careers. I was just having a chat with them before we started. All three bring many, many years in their organizations to the table. All three have seen cycles in this industry. All three started in different roles in their organizations and then were elevated up. And for me, just in refreshing my memories about the days back to when Nancy's a nurse at Roanoke Memorial, when Susan is practicing medicine before going into the C-suite. Randy, you're at Blodgett, and then you end up working for one of my friends, Alan Brass, at Toledo Hospital. It was just good to see good people commit to an organization for a career. And that's what you have in these three. So I'm just really happy you're with us. So here's what we're going to do. We're going to have a discussion with these folks about some very near term and then some longer term thoughts they have. We're going to also entertain your questions. So I think we've got a chat feature that you can use, and then we're going to let the audience at the end fire away as well. Am I right in that, Russ? You're on mute.
I'm sorry, I got stuck, Paul.
It's all right. We're going to have some questions at the end as well, correct?
Yes, correct. And we will work the chat box and filter them in as appropriate.
Okay, so I'm going to start, and there's an irony to the three organizations that are part of this discussion today. All of you are in markets where population growth has been not substantial. You're in markets that are not in that top 25 or 30 big urban markets. And it's also a fact that you dominate your markets. So I'll start with you, Nancy. You've kind of matriculated through Roanoke in your career, Roanoke's not growing. Roanoke is a great little community, and everything down I-81, you've got a great region. But what keeps you awake at night about opportunities in your market, opportunities to grow?
So the good news is that I sleep really soundly at night, and my husband's snoring sometimes wakes me up. You said unfiltered, right? So
Yeah.
you know, you're right. Our region is not as robust and growing like, say, Northern Virginia or even the Crescent area, which is what we call Virginia Beach, and the Richmond area. But we're in an area that encompasses about a 4-hour drive if you look at our catchment area. And we call it urban Appalachia. So we have urban, suburban, and very rural and very rural. And yeah, I would say going back as many as even 15 years ago or longer, we've been very concerned about the fact that we're the largest employer, actually west of Richmond, Virginia. So for almost more than a third of the state, we're the largest employer. That means we have to be concerned about the economic health of our region and the vibrancy of it, and hope and work to make it grow. So part of our job, part of my job, is to help lead those discussions and be very involved in economic development. And that has been accelerated, I guess, in the last few years, in particular through our relationship with Virginia Tech and Radford University, two large universities about an hour away, and trying to grow the region in a healthy way with jobs that are that pay well. And that's an important distinction, because you don't want just, you know, big box stores or manufacturing companies, that sort of thing. Not that there's anything wrong with that, but we're really looking at higher level jobs. So for instance, we've brought in about 600 physicians over the last about 6 years. And along with that, then more nursing staff, more faculty, and growing a medical school. We can talk more about that later if you like. Growing our research portfolio. So we're trying to change the way the economy is in our region, and through that we see more growth. I'll give you one quick example. There was an abandoned grocery store. It had been abandoned for about 4 years, and it was an eyesore because it was right on a main route, maybe 2 miles here from the main hospital. And we ended up buying it, repurposing it, spent about $8 million, and put in our Institute for Orthopedics and Neurosciences. I think there were more people at that groundbreaking than at anything else we've ever done, because they were so excited to see this abandoned building being used. But more importantly, around that, in about 3 years, we had another grocery store, a large grocery store, come up on the adjacent to the building. 4 restaurants now, a drugstore, and the biggest issue, it's parking. So, we're now in the process of renovating about 1/3 of an abandoned mall. It was JCPenney's that moved out, and that was the anchor store for that mall. And we're going to consolidate all of our children's services there. It'll take about another year, but already that mall is talking about how fast they're having growth, with restaurants asking about moving there, two new anchor stores interested. So the mall's actually changing, and just the signage and the paving the roads, those sorts of things are happening quickly just because we're moving there. So doing the right thing for our patients and providing services can also be the right thing for economic development.
Yeah, and a question, some would have is, so if you have the ability to spend the money to do all that other stuff, you're able to do that because we're paying your bills. So we'll kind of come back to that. This is that unfiltered discussion. Randy, you've been in the news a lot. The deal you did with Welltower, with Maynard Care, kind of put ProMedica on the map as really one of those really jumping into what was unknown space for a lot of organizations. So is anything keeping you awake at night?
With COVID now, yes, that has hit that industry as hard as acute care. So just because we have to isolate, and a lot of times in the senior world, you have 2 residents to a room. And so that's going to, present us a really difficult challenge next year. But yeah, similar to what Nancy was talking about, when we started looking at the future a little bit, and, you live in a non-growing community, we kind of got wrapped up in that we had to get a lot bigger. And yet the only way to do that was to throw the keys to somebody. And we decided we didn't want to do that. And then when we started looking at the senior world, the more we got comfortable with, that's where we thought healthcare was going. And it actually evolved over a couple of years. And so, yeah, it was a bit of some people would say a risk, but the more that it's evolved, it's created, we went from Ohio and Southeast Michigan to 28 states overnight, and we have just tons of opportunities that we never had before.
And while you did that, you had Paramount, right? Tell everybody a little bit about that.
Yeah, it's an interesting thing to think a little bit about. So we love this diversified model. The idea that you have hospitals, of course, that's kind of our core, where we all came from. We have had a health plan for 30 years. We have about 300,000 members in traditional, insurance, and we have about 300,000 in dental. And it's been, it's been great for us this year to offset, some of our other issues. So we like this idea. Then we've been employing doctors for 30 years. So we like this idea of being diversified. And, when people want to roll up 30 hospitals, not that we wouldn't want more hospitals, we like the idea of being able to grow, especially now with what we see on the senior world. We have more opportunities to grow in the senior world and in the insurance world than we do in our hospital world right now. And so that's where we see our growth. For example, we were in a community in Florida a week ago where there's a lot of HCR facilities, talking to some folks about doing a Medicare Advantage program together. That wouldn't have happened 5 years ago, but because now we have 6 facilities and a couple of communities down there, we're having dialogue, discussions we never had before.
Well, Susan, your scenario is unique from these other 2 in some respects. What I've always found interesting about you and the role you've played is what Nancy did is shift Carilion to a clinic-focused model. That's kind of what I recall the big shift was under her watch. And you've basically put Marshfield on a map from its roots as a big clinic model. Just for the listeners, if my count is right, Susan, 15 of your 25 board members are physicians. Is that correct?
It is.
That's a bunch.
It is a bunch.
When dealing with doctors and all that's going on, what's keeping you awake?
I think I'll go back to a couple of things that Nancy said and you just mentioned in the intro. We're located in an area of Wisconsin that is pretty economically depressed. And in fact, in our service area, we serve some of the oldest, sickest, poorest patients in the country. And if we go back to 2008, during the financial crisis, many of those areas have not recovered. And now we're facing another crisis, both economically as well as healthcare, because we are the largest employer in most of our communities. And we are not in any urban area. We are mostly in communities less than 2,000, even though we have about 1,250 providers, over 12,000 staff. We are very dispersed across 45,000 square miles. So when you think about that, in our roots, we started out as a clinic. We've been a clinic for well over 100 years and grew our ambulatory footprint across our geography, but only in the last 5 years have we really become a hospital health system. So of course, physicians have been very important throughout our growth. They were leaders within the organization. And when the health plan, our research, our education, and the care delivery came together as a health system, having physicians part of that transition and continuing in leadership roles was very important. And we do have clinic board members that sit on our board, and we also have independent physicians who sit on our board and are actively engaged in really helping us not just execute, but define our strategy, which has many unique aspects because it's rural. Our communities we have a large geography, so people have long distances to travel for care. We have communities, about 12 to 15% of our communities do not have broadband access. We have a very old population. We have counties in our service area where we have less than 1.6 people working for every Medicare beneficiary. So when you think about it, you might ask, why are you here? And why are you doing this? And I have a deep passion for the communities that we serve and realize that we've learned to be successful in our rural geography and meet our patients where they're at. And as I think about what keeps me up or wakes me up in the morning, it's really the people and making sure that we continue to support our staff and making sure that we have ways to take care of our patients that might be different than in other parts of the country just because of where we're located.
You know, all three of you represent organizations that have chosen to pursue fairly independent paths. One of the questions that came in was about the prospects for one of you doing a deal with a certain named other. I'm not going to name that. I'm going to, that would be crossing a line that better crossed with your own boards. But step back. Is there a scenario in which any of your organizations would say, we're just not big enough or strong enough, we've got to figure how to be part of something bigger? And we talked about this the other day in our call, and we talked about scale and what's the necessary scale. So let me just open it up. What would be your reaction? Is there a scenario in which you could see yourself having to be part of something bigger, or no, not on our radar?
Or yourself being bigger. I mean, you know, going from 1 to 28 states.
Well,
so
they're all doing that. All three have been expanding themselves, the footprint they have. But this takes it to a different level.
You know, maybe I'll jump in because that question was very provocative, and it was something that actually we've talked about in our leadership team as well as at our board, and really is bigger, better in healthcare. And from my perspective, the argument really is more around the system of care, which I believe is best. It means building, you know, the infrastructure for care for the full patient, making sure that we provide prevention, management of disease, coordination between providers, and reaching deep into our communities around social determinants of health. So I think any system has to be structured in a way that really meets the needs of the communities, the patients that we serve, that And for us, we want to be able to provide that care as close to home as we can without sacrificing, obviously, access to the highest possible level of care. So in a sense, we have gotten tremendously bigger. 5 years ago, we have no hospitals. We now have 10. We have also expanded our programs to take care of patients outside of the construct of the four walls of the organization. When we look at behavioral health, when we look at hospital at home programs, when we look at home recovery care. So it's not an either or, but I think sometimes just getting bigger is not the answer. It's really addressing what the needs are, because that seems to be more of an end in and of itself. And in order to become a fully integrated system with our health plan and our ambulatory care, we needed to have hospital presence so that we really could deliver on our promise, which is to provide care as close to home as possible, and also across the entire continuum, and to make sure that we had the infrastructure that could really support that integration.
Yeah, I would jump in and say, ditto to everything Susan said. You know, it'd be irresponsible if we didn't constantly look at what's the future, try to get our periscopes out and see around corners and figure out where's the future going to be and what might it look like. We do that regularly here, both the leadership team and as well as with the board. When I became CEO in 2011, there was a lot of conversation about, well, that just must be temporary because they're going to sell. Of course, we haven't 10 years later. We believe that there's real value in being nimble and making decisions for yourself. And one of our values is collaboration. So we, sort of actively look at, are there ways to collaborate or partner? We don't have any good examples of that right now. But also, and I really appreciate Susan's comment, just getting larger to get larger, about the best thing it does perhaps is give you a little more muscle with the insurers, but it takes away your decision-making, your nimbleness, your being able to quickly understand a region and make decisions for that region. And so what we're looking at in terms of growth, and what we've already done are urgent care, retail services, really moving into the ambulatory space. And I don't negate or suggest we won't ever get larger with more hospitals, but that's not what I see on the radar at this time.
I'm hearing scale and scope to sustain a level of growth, but other than fulfilling a fiduciary obligation to listen to any offer, our course is set on remaining as we are, but growing. Is that fair?
Yep.
Randy, you had an interesting thing I read. When Flower and Toledo came together, there was some discussion about whether you should go for profit.
Right. Yeah.
And your board said, no way.
We've had that discussion several times over the years. We actually went through a process with another not to be named system a couple of years ago. And, I just look back, I don't know if it was my fault, but it was kind of like I kind of let us down the road. And at the end, we decided not to do it. And our board members would say, well, that was a waste of time. And we said, no, it's the best thing that ever did, because what we realized, and nothing personal, was not that they didn't care about us, but they didn't care about the things we were doing. We were just another dot on the map. So we kind of came out of that and said, it's up to us. We got to make our own way. Similar to what Nancy and Susan said, the anchor institution work we do, the investment in social determinants, the folks who we were talking to, that just wasn't their DNA. And so we said, hey, we got to own our own future. We got to make our own path. Nobody's going to care about our communities like we do. So I think we actually ended up getting more, dedicated to be independent than ever before.
Yeah, I think what I appreciated about what I was reading about your plans, and I'm thinking, what kind of conversations does that provoke with the board? How much time and effort does it take now to bring boards along. And what I remember from AHA's work a few years ago is it was about a 200-hour-a-year commitment to be a member of a hospital board. Does that sound roughly right?
Yeah, I think that's exactly right. Even now, we have board members that, a year ago would have said we have 3 different companies. We got a provider company, we got a senior company, we have an insurance company. And partly, yes, but partly the magic is what happens when you put all 3 together and you think about care models, you think about the things we can do, both from using the strength of each part of that, those 3 entities and kind of supporting each other. And then the other piece is just allows us to think about ways to compete with private equity, rather than watch them just own the world. Gives us some opportunity to go into places that we had traditionally never gone to because we have just a different DNA than we did, 10 years ago.
Paul, I think you asked a really interesting question, and that is how to keep the board informed, because we live this every single day, and yet our boards have other jobs, other things to do. They're still so devoted to the community and improving health. And I suspect that's true for all 3 of us. But keeping them informed, up to date, and it's a pretty significant job, I think. And it's hard because things change all the time. And as they're evolving, people can hold on to a piece of information, and 3 months later it's changed, and you got to bring people along. So I think one of the biggest surprises for me, frankly, when I became the CEO, and it's still true, is how much time board relationships take.
Yeah.
And these are people that I care deeply about, and I think they care about us, but keeping them up to date and helping them make decisions and provide leadership, that's not as easy as it seems.
Yeah, let me put you on a spot, all 3 of you. So you probably are working 80-hour weeks. It's not a 8 to 5 job. What percentage of your time do you think you are necessarily spending on board-related stuff? Just roughly. What do you think?
20%.
Yeah, I was going to say 25, 30%.
Wow. Susan?
Yeah, I would say close to that. And we have a little bit of a different structure because the health system is the key enterprise, and our hospital Inc. and our clinic board and our health plans sit underneath the health system. So collectively, I'm sure it's at least 20-25%. Plus, just the staying in relationships with your board members. I mean, even though we communicate in writing and we have call-in sessions for information and we have our regular board meetings, there's a lot of information gaps. And depending on when people come on the board, what industry they come from, because not everyone on our board is from healthcare and they live in different geographies. So it takes a little bit of time to understand the uniqueness that we have as a health system. So it's a big commitment, and certainly worth the investment.
I think one of the things that I find the board members have the most difficulty with is understanding a not-for-profit health system and how we get paid. Mm-hmm. Most come from a for-profit world. They just don't get it. And the fact that you can offer one service and get paid 25 different ways and 25 different amounts, and that changes, it's mind-blowing to them.
The board as a whole, it's a long discussion. The NACD data for private organizations says the number one concern of board members is they don't feel they're involved in strategy. They feel left out of strategy discussions. And yet most of our boards don't put in the time. A public company board is 400 hours a year, and that allows them to spend a little more time on that. But another discussion. I want to shift it again to another group, your C-suite. Russ and I talk a lot about this. What's the competency collection in the C-suite post-pandemic? What do we start to look like that maybe is an adjustment from where we are today, talent-wise, or the area of competence that we really think has to be added to our current, bag of tricks? Do you have anything like that in place? Do you kind of have a sense of, here's what I think we need to be thinking about?
And just to add to that, do you feel the need to bring people in from outside the industry to work on your team?
Mm-hmm.
So I'll jump in. I'll tell you, I thought that we had a great team pre-COVID, and we were working hard together and doing a lot of cool things. And COVID happens. And COVID continues to happen. Humans are pretty good at crises, and healthcare workers are incredibly good at crises. But nobody can sustain a crisis forever. And in fact, I think there's good data that humans can pretty much stick with a crisis about 5 weeks. Well, we're now what, 8 months into this? And I've been so impressed with the resiliency of our frontline workers, also the resiliency of our leadership team, and in particular the C-suite, who we decided early on, I guess I decided, and I hadn't thought much about that until people start reflecting it back, we would not work from home. If our frontline workers, were expected to be here and care for patients, then we were expected to be here. And so everyone in the C-suite's pretty much been here now for 8 months, every day of the week, literally every day of the week, we're all here, and just remarkable people. So you ask an interesting question: will we pivot? Is there something different that we would bring to the C-suite post-COVID? And my knee-jerk reaction is no. We were, I think, a talented group of people who were working really well together, spent a lot of time thinking, strategizing, working hard, focusing on operations and finances, providing quality care, improving the health of the communities that we serve, and living our values. Do we need something else going forward? I don't think so. The thing that I may want to stretch us in is in the area of technology and telehealth. We pivoted fast. We're learning to do that better, and I think that's part of the future, and we can talk more about that if you like. But just in terms of the characteristics and the abilities of the C-suite, I couldn't be more impressed and thankful for the team that we have.
I went through the websites and looked at all the titles for all the leadership teams. And the three of you, if you put a list of all those titles without names next to them, you're very different. You've got some very interesting titles and very interesting roles. And I think that reflects how every organization evolves and becomes its own thing. So Randy, Susan, is there some additional set of skills or competencies you think you need to be adding to your team?
I'd probably list probably 3 areas. So we, of course, blended a for-profit, 40-year for-profit organization into our organization. So very different DNA. So we blended that, and just as and I think Nancy described a lot about kind of what we've seen out of our teams during COVID. But the areas that you start to worry about is communications. It has got to be done at such a higher level than we ever done before. We ask ourselves all the time, do we have the right people and the effective ways to do that? The whole consumer piece that healthcare traditionally hasn't been very good at. And then as our innovations group has evolved, and now we look at startups and supporting startups and doing startups, that's not in our DNA. That's not our strength. And we're struggling, to be honest. It's just, we have opportunities and we're just trying to figure out who are those people that can help us there, and that's a different skill set. So I think we would look to go outside of the organization. We've done it a number of times and just have had great success. So those are probably the 3 areas we would look at.
That's good. Susan?
I've been in my current position for 6 years, and we've had, as you've already pointed out, tremendous change. I mean, to go from 0 to 10 hospitals in 5 years, building and acquiring across a wide geography, has been tremendous change. And I think we've had the right people. And I suspect the people won't change, but I think the roles will change. I think that's what we're going to be seeing. And, you think about the delivery of care, telehealth is going to continue to expand. Our patients love it. Our families love it. It extends our reach deeply into our communities. So as we think about the changes that we're anticipating over the next 12 to 18 months or 2 years, I think that people are just going to have to move quicker than they ever had before. They're going to have to remain very nimble and agile and responsive to the environment. And I think a lot of the driving changes are going to result from things that have happened during this last 8 or 9 months. People have they've become accustomed to receiving their care differently. They have appreciate that we're responsive and that we are taking care of them differently. So I think it's really not so much reaching out and bringing other people in. It's making sure that the people that are with us are expanding, and then reaching out to the industry for things around machine learning, around artificial intelligence, around other tools that are really going to help support us be successful. But it's kind of a tough question to answer too, because I'm not sure. I'm challenged to even understand what we're going to look like 12 to 18 months from now. So
Yeah.
I always reserve judgment about what my plans are for the C-suite. But we've got some incredible people that have really expanded their abilities to really reach deep and broad and really move us forward during a time where I think a lot of people thought we might have to stand still. So I'll reserve a little bit of judgment, but I think we're going to have the same people with partners that are needed, on an ad hoc basis.
The one thing I would say that is clear now are the issues related to social issues. And, Randy, I know, has spent a lot of time working on social determinants of health. COVID just shined such a bright light on inequities in care. We've got, if there's one thing that we've got to focus on, I think it's it's the idea. It's inclusion, diversity, equity, and access. And that is something that COVID shined a bright light on. We were all talking about ahead of that, but we've got to accelerate that work.
All right, I'm going to truncate our. Yeah.
We have several COVID questions coming in. I think we're in three different. What I wanted to do
was get to a couple of these questions that folks have had about this current discussion. Then I want to pivot over to, in the last few minutes we have, to pandemic. In kind of a lightning round, if it's okay. The question we have from Sarah Larch, it's, we talk about scale, community responsibility, social determinants, spinning the clock forward a year, what changes do you project for your system? And then John Matthew sent a similar note, really drilling into how much more emphasis will you be putting on social determinants? Are we just talking the talk, or are we really walking it? How much time and money are we really seriously putting into social determinants? So what's your answer, folks?
For us, it's core to what we do. We've got quite a large team. We've got 20 people working in social determinants of health. More recently, we couple that with the personal determinants of health, which is life purpose. So we actually invested in a company in Ann Arbor, Michigan called Kumano, which is a life purpose company. So again, when you think about total health and well-being, we talked a lot today about clinical, but that's just a small part of our daily living, as we know. So if we don't start addressing social determinants and this notion of if you have a life purpose or not, there's a lot of interesting research. So we're actually forming a screening tool with Kumano to look at social determinant in life purpose interventions. So yeah, it's, I would say it's integral. If you look at our strategic plan, it says that we will be a leader in social determinants. So it's core to what we do.
I see Susan and Nancy nodding, so I'm assuming we're all doing a lot more than just talking about it. Here's an interesting question from Seth. Do you foresee a world where less than 50% of your care isn't meaningfully value-based, meaning two-sided risk? In other words, and one of my questions later was going to be a kind of a lightning round on, is this value-based care stuff more smoke or substance? So question, 50% of your care isn't meaningfully value-based, meaning you assume two-sided. What say ye?
Well, you know, I think having a health plan and having a practice, we are fully capitated, so we assume full risk. And we've been in value-based payment models for over 20 years, going back to the group practice demonstration project. So I think we probably will continue in this realm, and I see no reason why we would roll back the hands of time. Yet the investment needed is huge for an organization. When you have a diverse population, there are a lot of inequities in the communities that we serve, and we have, you know, basic needs that need to be addressed in our communities. We have people who have no transportation. We know that 1 of 4 children go to bed hungry. We have incomes that are substantially less than the state and national average. So we're trying to fill some huge gaps in our communities, at the same time trying to promote what's best around their preventive and their routine care, as well as chronic, sick, and acute care. So, you know, you have to kind of manage both sides of those, and it's not an easy challenge, but it's something that we're committed to, and we've been doing for 30 years. And I don't see that changing. If anything, it will accelerate.
All three of you have large numbers of employed physicians. I was surprised at just how large those numbers were. It's not a couple of hundred, it's several hundred or 1,000 or more. So one of the questions from one of the listeners is, how does the relationship with external independent physicians change? Or is, just to ask, is an independent physician an oxymoron? How do you deal with that?
I think what's an oxymoron is that an employed physician isn't independent. I think physicians are independently minded, and they always have to be to do the work they do. But we employ a lot of providers. We employ about 1,000 physicians. We have another 350 residents and fellows, and then we have, gosh, I don't know, several hundred advanced clinical practitioners. Those are employed by Carilion, but we have several hundred physicians that are in private practice who work side by side with us. And I think that model works. It can be uneasy at times, but I don't think it's where your paycheck comes from necessarily. It's the value we have to go to care for those that we serve.
Randy, Susan? This is
I think it's hard. You know, the larger our group has gotten, the more difficult it's gotten with independent groups. One of our groups that's independent, they call us frenemies. You know, we're friends, but we're enemies. And their idea is, the more we, execute on our strategy and growth, it hurts them. And it's logical. It's, as we continue to grow and develop and fill gaps that we need to fill, it gets more and more difficult to have these relationships. We try. It's very difficult to find models these days that work for independent groups. So yeah, no, I don't have an answer for it. It's just flat hard, and I don't see it getting any better.
Yeah.
I do think that physicians in private practice going through COVID don't have the financial reserves, and you're seeing more physicians in private practice now saying, you know, I think I'd like to be employed. What's that look like?
Right.
And private equities coming in and doing some interesting deals to kind of give them a different option. We got a lot of great questions here, but I want to shift, if we can, to a few minutes on the near term. Pandemic, vaccinations, logistics, access to drugs, the workforce. So right now, what are your assumptions about any post-pandemic return to normal operations? Are you thinking this is second quarter next year? Is it third quarter? Is it to be determined? What are you thinking?
So, you know, we've sort of learned to chew gum and walk at the same time. So we have a lot of normal operations. We obviously have a big COVID unit, and there's life isn't as we knew it. So there's a screening process. There's fewer visitors around, and our, and staffing is a continued challenge. It's because of exposures or staff with COVID. But if you say, when's COVID going to be yesterday's news, not current news, I think it's going to be next summer.
Mm.
I think that one of the challenges that we've had is that we are now right in the midst of this catastrophic surge. So what we are doing is really trying to plan for every contingency rather than create assumptions, because we have seen that this is completely unpredictable, and that so much depends on the actions of the individuals, which have been unpredictable and often inconsistent. So we're learning that the best thing for us is to be nimble, to be flexible, and to really meet the shifting needs of our patients in our communities. And I think it's impossible to forecast the duration of this pandemic, although we do have some hope on the horizon with the vaccine news, certainly medication and treatment, and perhaps even a new administration. But in the meantime, we're doing the best. We're doing the best we can to really stretch ourselves to meet our current needs and to get through the next 6 to 12 months, realizing that just when we think we figured it out, things are going to change.
Yeah, we're thinking third quarter at best. So even in our budgeting and board meeting this morning, we're talking, we don't expect to see significant changes till third quarter, if not fourth quarter of next year.
You've got a couple of interesting questions here from Bonnie and Jack, specific to pandemic. Does this put on the radar some of the rural hospital relationships? Do you give fresh thought to how you might partner or integrate rural health in a different way, given where we are with pandemic?
Mm-hmm. Well, being the largest rural provider on this call, rural health was in crisis before the pandemic. So we know that rural health is going to look a lot different going forward. Many critical access hospitals are at risk of closing. We, prior to the pandemic, we had no hospitals in Wisconsin, rural hospitals that were at significant risk of having to shut their doors. And now we're finding that we are on the watch list, and as many as 10 or 15% may be at risk of closing. So I think right now we're trying to help each other and to work through the pandemic and share and provide services and accept patients where we can, so that they can remain vital. The healthcare is it plays a very important role in our smaller communities as far as the economic status of those communities. And if we lose those jobs, it's pretty devastating to the people that live there. So we want to do what we can to support our partners, but it will look different. There's no way that it can't.
Have you any thoughts on a different approach to rural health?
Well, I would say I have two things. One is the extension of telehealth, which we were doing pre-COVID, but we've really accelerated. However, as Susan mentioned, a great deal of our rural areas don't have broadband, so we're relying on phone lines.
Mhm.
But so we've had a couple of interesting and I think very positive things happen recently. Well, not so good. A hospital closed, but it caused that community to partner with us, and they're using some of their CARES funds donated to us so that we can provide some services, particularly some outpatient services in communities. And that sort of partnership would not have happened prior to COVID. So creating those kinds of partnerships might be very helpful going forward.
Randy, any new twist on rural health as you look at it?
No, I think it just gets harder and harder for rural facilities. Those that haven't aligned with people, it gets difficult, especially as you begin to look at deploying capital, IT, and, you're in circles with leaders, and then you hear people about that they would look differently at rural health than they ever would before relative to acquisition. I think to what, Nancy and Susan said, support them all day long, help them all day long. But it takes a real hard lift to say you're going to put somebody on your balance sheet that has no cash and a ton of needs. And I think, you're hearing more and more of people to say, I'm not so sure we would acquire another struggling rural hospital.
Mm-hmm.
All right, I'm going to throw a couple of little lightning round things at you. By the way, any of you that have been listening, none of this was rehearsed, so that's okay. But just some things that come to mind that I'd like you to react, and that's not something I'm particularly worried about. That's something we ought to be paying attention to. No harm, no foul. So they don't have a clue what I'm going to ask, but here's the first. The Amazon factor in healthcare. Big deal? Worry? Concern? What do you think?
I think we have something they don't have. We've got caregivers. We have the ability to integrate at a very high level. They're going to kind of, chip away at the ends, the edges of what we do every day, and they'll take some business from us. But, they don't have the core of what we do each and every day. And I think if these things come in cycle, and if healthcare begins to become more consumer focused, we compete.
Is that worrying you, Nance, Susan?
If you'd asked this question a year ago, we might have given you a different answer because it was quite popular then to be worried. And look what's happened a year later. I think that even the Amazons have figured they can't do what we do.
Haven hasn't exactly turned the world upside down. Okay, advocacy. I looked at your operations, each of your three organizations. You actually operate across 6 states. Actually, with HCR, you operate in 26 others in addition, Randy, but your core operations, inpatient, outpatient services, your insurance products. So as advocacy seems to be a big deal at a state level, with a Biden administration coming in, likely putting a governor in HHS, what will be the directive to your advocacy team that you'd like to see get attention over the next 2 to 4 years?
I thought you were going to ask a different question. When you asked how much time do we spend with their board relations, and we all said about 20% or plus. I think another 20% of my time is the political animal, and that's pretty depressing, isn't it? What am I doing? Clear direction to our advocacy team. We only have one full-time person, but have a team that provides some other services. Is focus on the state, because that's the real opportunity with Medicaid. and other rules and issues that are really important to us. Really excited about the Biden administration, but I don't see much change, frankly. I think we're still going to be the target of having to reduce cost. And what does that mean? I'm very concerned about Medicare for all, or some public option. I'm very concerned about transparency, about drug pricing, about all the things we've been talking about for so long. They're not going away with the Biden administration. So spending more time also at the federal level is something our advocacy team needs to do. And then lastly, at the local level, because we've seen that the Board of Supervisors or City Council, whatever, have a lot to say about how do you want care to be done and what kind of needs you have. And as Susan mentioned and Randy mentioned, with rural hospitals potentially closing, that doesn't mean healthcare needs go away, but how can we do it differently, and can we partner with the local legislators to create some good options for healthcare?
Randy, Susan, advocacy directives.
We got 3 issues: National Commission on Health, because nothing's going to change the healthcare model. We're just, kind of just, running along. Nothing's changed. Value-based purchasing isn't really working. We know that from a cost standpoint. Don't reverse on telehealth. Keep funding for telehealth because we're onto something. And mandate social determinants of health.
Good. Susan?
Yeah, I would support that. I think for us, it's just the vulnerability that we have based on the demographics of those that we serve, and staying very actively involved in economic development, on making sure that our patients are covered for care that they need, and not rolling back the hands of time as far as the new models of care delivery are emerging and have been proven to be successful, that we continue to push that out to really meet the needs of our patients and communities.
Well, you 3 are awesome. We've run up against our clock, and I'm going to turn it back to Russ. But I will say, you've earned respect of your peers because I had a friend who referred to people like you as burning with a clear blue flame. And I believe that to be the case for each of you. So thanks for today. Russ, turn it back to you.
I just echo that. Thank you, Nancy. Thank you, Susan. Thank you, Randy. And Paul, also thank you for moderating the discussion. I hope all of the folks listening in enjoyed the conversation. And I'm saying something that I hope I wouldn't be saying at this time, but given the COVID situation, again, stay safe and take care of yourself and your loved ones, and all be well, because we do look forward to having you all back on another webinar sometime after the turn of the year. So be well, everyone, and thank you very much for attending.
Thank you, everybody.
You.
Appreciate
Bye
it.
now.
Thank you.